Welcome to our course on the principles of pain management in palliative care. This session is going to focus on pharmacologic therapies that are used to treat significant pain. Our goals of treatment include preventing pain whenever we can, relieving it, of course, improving function and quality of life, always in a safe environment. And given our current environment, we also need to prevent diversion of many of these very powerful medications. When we evaluate our options, we basically have three broad categories of pharmacologic therapies: non-opioids, opioids, and adjuvant analgesics. If the individual has cancer, there may be some disease-modifying therapies or anti-cancer therapies that can be useful in relieving pain. So let's talk about each of these groups of drugs. Acetaminophen and non-steroidal anti-inflammatory drugs are part of the non-opioid group. Acetaminophen, also called paracetamol around the rest of the world, is analgesic, antipyretic. It does not have any anti-inflammatory effect. So in general, it's not always the best agent for pain that's derived from inflammation like arthritis or bone metastases. The safety of acetaminophen, despite its being available over the counter, is now being questioned. It is one of the leading causes of visits to the emergency department, leading to liver failure. And so as a result, the FDA and other organizations have recommended that the overall dose of acetaminophen be limited. And this gets complicated when patients are taking medications that have been prescribed that are in combination, such as oxycodone with acetaminophen or codeine with acetaminophen or hydrocodone with acetaminophen, and then are also taking over-the-counter medicines such as cold medicines or sleep aids. In general, the maximum daily recommended dose is suspected to be around 2,000 to 3,000 milligrams per day. We used to teach 4,000 milligrams max, but that was never demonstrated to be safe, and it's likely too much acetaminophen. The non-steroidal anti-inflammatory drugs are also in this non-opioid category. They are analgesic, antipyretic, and anti-inflammatory, and they work partly through prostaglandin inhibition. The toxicities, though, can be pretty significant: gastrointestinal ulcers, renal compromise, problems with platelets forming a clot, and then more recently we've learned that in patients who are at risk for cardiovascular events, non-steroidal anti-inflammatory drugs can lead to myocardial infarction or stroke. And so as a result, even though many of these drugs are available without a prescription, we need to be cautious about their use, particularly in the person who has multiple comorbidities. And in one systematic review of the use of NSAIDs in people with cancer pain, NSAIDs appeared to be more effective than placebo, but there was no evidence to support the superiority of one NSAID over another. So in many cases, we try one in the appropriate patient, and if it's not effective, we might try an alternate agent or rotate to a different NSAID. So that leads us to our second category of drugs, which are the opioids, which are the agents that we rely upon heavily in palliative care. And here's a list of the opioids that are available in the United States, and those that have asterisk are also available in long-acting formulations. The great thing about having all of these different drugs is it allows us the flexibility when one is not effective or if it creates adverse effects, we can rotate to a different opioid. So the question always comes up, which one do we use first? And there was a very nice systematic review that was published that really suggested there's no gold standard in terms of which one should we use first when treating patients with significant pain, that it really depends upon particular patient, their past experience with these medications, and oftentimes it really is more of a trial and error. So when we are switching from one opioid to another, if the patient doesn't obtain adequate relief, we calculate what we call the equianalgesic dose, so that we're comparing apples with apples, because the doses of these drugs can be quite different. Once we establish an equianalgesic dose, we reduce that by about 25%, because when switching, for example, from morphine to oxycodone or from oxycodone to hydromorphone, the tolerance between these drugs might be different, and we don't want to overdose the patient. So then we would frequently reassess and bump up the dose if we need to, making certain that the patient has rescue medication on board. And this is just one of many equianalgesic tables that help us to determine how to compare one drug to another. So again, we're comparing apples with apples. Now, we have to choose a route of administration, and for the vast majority of our patients, the oral route is the best. It's the simplest, it's easy for patients, it's often the least expensive, but other options are available when patients have difficulty swallowing or they have pain in the oral mucosa or in the esophagus. But the one way we don't want to give these medicines is through the intramuscular route, simply because it is painful and it leads to great intravariability between the uptake of the drug. Many people ask about topical delivery of medicines. There are transdermal patches, which are usually fentanyl-based, which are wonderful. Fentanyl is lipophilic. It crosses lipid membranes, and our skin is made up of lipids or fats. Some people have suggested using topical morphine, but studies have not borne out the efficacy of the topical morphine. It simply does not cross the skin. And others have questioned topical methadone. The same thing is true. The serum levels have been the same after topical methadone when compared with placebo. Now, others question the efficacy of transdermal fentanyl in very cachectic patients. And for those of us working in palliative care, many of our patients have lost a significant amount of weight. Well, there are very few studies that have explored this. This is just one. And the authors do see that there is a lower risk, a lower serum level of fentanyl when it's applied to very thin patients. However, they do absorb the drug. And since we're basing our treatment on patient response and not necessarily on serum levels, we need to try this empirically and increase the dose. So many individuals have wondered whether we should even use a fentanyl patch in patients who are cachectic. We can try and increase the dose to meet the patient's needs. Now, fentanyl is lipid soluble, as I mentioned before, and as a result, it's being used for breakthrough pain because it does cross into the bloodstream faster. And there are numerous breakthrough products. These include transmucosal fentanyl products, buccal tablets, sublingual tablets, films, and sprays. But all of these require special privileges to be able to prescribe these medications in the United States. And this is called the REMS program for TERF products. So risk evaluation and mitigation strategies for transmucosal immediate release fentanyl-based products. This doesn't apply to patients who are in the hospital or in hospice, but it does apply for outpatient prescribing. Prescribers need to take an educational course online and answer a brief questionnaire. The third category of drugs we use are also called adjuvant analgesics, and these include a disparate grouping of medications: corticosteroids, anti-seizure drugs, antidepressants, local anesthetics, NMDA receptor antagonists such as ketamine, and yes, cannabinoids, which have been in the media quite a bit lately. Dexamethasone is a wonderful corticosteroid that can be very helpful for bony type pain as well as that right upper quadrant pain that we see in patients who have liver metastases. We do have to be cautious about drug-drug interactions, particularly with some of our newer chemotherapeutic agents. Anti-epilepsy drugs in the past were of limited use because of their toxicities, but since the advent of gabapentin, which is also called Neurontin, and its related drug pregabalin, these drugs are very well tolerated and can be very helpful for that tingling, burning, electrical type of pain. There are older tricyclic antidepressants. The one that has been studied the most and is probably the oldest drug, amitriptyline, we tend not to use quite often because it has the worst anticholinergic profile. Instead, we tend to use nortriptyline, dizipramine, or some of the newer SNRI antidepressants like venlafaxine, which can be very useful, or duloxetine. Both of these are serotonin, norepinephrine reuptake inhibitors and can be helpful in relieving neuropathic pain. Local anesthetics are somewhat limited, unfortunately. We've got different creams and patches. These work pretty superficially and they don't typically work for deep kinds of pains. IV lidocaine has been used in the palliative care setting, as well as epidural or intrathecal administration of local anesthetics such as pivocaine. And then the cannabinoids, and many states now have invested in medical marijuana. Some of them have even allowed recreational use of marijuana. The cannabinoids seem to be working through different receptors. There are 2 known cannabinoid receptors. There are approved products such as dronabinol. That is basically used to treat HIV-associated wasting and chemotherapy-induced nausea. A newer product which is only approved in Canada and in numerous countries in Europe, not in the United States, has been shown to be very effective for spasticity associated with multiple sclerosis, as well as neuropathic pain and cancer pain. In the United States, it's only been approved for the use in clinical trials, and there's some provocative evidence that it might actually inhibit metastatic growth. So I've reviewed for you quite a few different agents that can be used in palliative care to relieve pain. Thank you for your attention.